Welcome to the Essential Substance Abuse Skills webinar series. I am Kate Trams, and I will be administering today's webinar. Today, Bob Rarrett will be speaking on treatment knowledge. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the locations of the 4 national focus center ATTCs. To learn more about our center, the network, or your regional center, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and in previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam that you seek additional preparatory help and let this course be one of many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, April 16, when Denise Casillas will present Clinical Evaluation Assessment. In addition to this webinar series, we offer another series titled the American Indian and Alaska Native Behavioral Health Webinar Series, which presents on current topics of interest in the behavioral health field. The next session in this series will be held on April 2nd from 1 to 2 p.m. Eastern Time, when Dr. Barbara McCready will be presenting on cognitive behavior therapy for substance abuse disorders. For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified education provider, and we'd be happy to provide you with CEHs. The cost is $10 to do so. The CEH request form is available for download in the Files pod in the webinar screen. If you choose to download a file, the new tab will be opened in your browser and you'll have to click on the webinar window to return to view the webinar. If you're unable to download the documents from the webinar, please contact me using the information on the slide. Immediately following today's webinar, you'll be redirected to our GIPR evaluation. We invite you to participate in this brief online customer survey. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPR stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you'll assist us in gathering information about our services by participating in our survey. Before we start today's session, I'd like to go over a few instructions for the Adobe Connect system. To view the presentation in full screen mode, click on the full screen button, which may look like 4 arrows pointing outward, at the top right corner of the presentation pod. To return to the regular view, click the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments. We will be actually taking a few times throughout the presentation today to take questions, so submit them at any time, and we will have Mr. Rarrett respond to questions as much as we can and as they come in, and we'll keep an eye on those questions so that they can be pertinent to what's being discussed at in a timely fashion. We'd also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Bob Rarrett. Mr. Rarrett has worked in the field of addictions treatment for 20 years. He's been internationally certified through the IC and RC and is currently employed by Ramsey County Human Services as the director of a 50-bed medically monitored detoxification program in St. Paul, Minnesota. Bob has experience as a clinician, a clinical supervisor, senior manager, director, and executive director in a variety of settings. Mr. Rarrett, I thank you so much for joining us, and we look forward to your presentation, and I will pass things over to you at this time.
Okay, thanks very much, Kate. And welcome everybody. Good morning or afternoon, depending on where you are. Let's go over the training objectives quickly here. And I do want to preface this with a statement that, as Kate mentioned, I would like to take questions along the way. This training is meant to be helpful to you, and I need to know what kinds of things would be helpful for you to know. So please don't hesitate to ask questions along the way or ask me to focus on a particular area in a little more depth. The more interactive this is, I think the more interesting it can be. The goals that I've laid out for the training here are to gain a better understanding of evidence-based practices, best practices, and promising practices, to gain a better understanding of the importance of the treatment alliance, become familiar with commonly used evidence-based and best practice approaches. Now, if you're studying for the exam, for the certification or licensing exam, we're not going to cover every therapeutic approach that would be asked for on the exam. I will make reference to those that I think will be most important to focus on. Number 4 is to better understand co-occurring disorders and integrated care, excuse me, and explore medication-assisted treatment. Primarily buprenorphine is what we'll focus on. Due to time constraints, I didn't include much about methadone. There we go. Evidence-based and best practices. I think a lot of times these terms are used interchangeably. There is a difference. There's a difference between evidence-based best practices and promising practices. I just want to clarify that a little bit. If you think of this in terms of how rigorously a particular approach has been studied or in clinical trials has been evaluated, evidence-based practices would be the most scientifically based or supported practices. Best practices are, as you can see here, they've shown superior results and then have been achieved by other means, and will likely evolve as empirical research advances. Promising practices may not have as much research behind them, but they may show promise either through evaluation studies or because respected bodies have excuse me, supported them. And the opinions of those respected bodies matter, of course, to the field, and usually they're well known. So I just wanted to take a second here to provide a little more current, maybe, description of what addiction is. These are characteristics that were drawn from the new ASAM, American Society of Addiction Medicine, 3rd edition. And ASAM describes the following as characteristics of addiction: an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. I think a relatively recent conceptualization of what addiction is. As the field develops and evolves, our understanding of what addiction is also evolving, and it obviously will affect the field and how we move forward as professionals. So, as professionals for treating substance use and co-occurring disorders are to properly assess the client using multidimensional tools. As we advance, as I said, and evolve in this field of addictions treatment, we're going to have to start thinking in terms of whole person care, integrated care, and better coordinated care. So when I talk about properly assessing the client using a multidimensional tool, I'm talking about things like ASAM, something that looks at various dimensions of a person's health and assesses each dimension while understanding how those dimensions interact with one another and influence one another. I use ASAM as an example. It's one of the most widely used and and best understood tools. It's one of the few common languages that we have in this field other than the DSM. So by using ASAM as an example, I'm sorry, using ASAM as an example, you can be a clinician in California or a clinician in Maine and still have a common frame of reference for how the person was assessed if you're using something like the American Society of Addiction Medicine criteria. Another goal is to provide integrated and coordinated longitudinal care using evidence-based approaches. Longitudinal care refers to providing care for the duration of the person's need. So again, we're moving away from time-limited treatment approaches. The days of the 30-day or 28-day treatment stay are coming to an end. As we advance our understanding of addiction, we also understand now that it fits more, that is, addiction fits more with a chronic disease model rather than some acute care model where the condition is treated briefly and then the person is released. Studies have shown and research has shown that long-term care at varying levels of intensity for the duration of the client's need are much more effective and they make more sense. Another goal is to provide an optimum opportunity for healthy behavior change through the Therapeutic Alliance. I'll talk more about the Therapeutic Alliance as we go along here. And to improve the client's overall health and wellness. Really, that's the ultimate goal. Abstinence may not be the client's goal. It may not be something that they're able to achieve at the moment, but we always want to keep in mind what kinds of things is the client willing to do, what kinds of things can I assist them in doing that would help improve their overall health and wellness, even if abstinence is not a goal for them at that point. I think this is the last one, but it's very important to measure outcomes. We have to show that what we do is effective or that what we do is not effective. Either way, it's meaningful. So as we look at any of these evidence-based approaches, they were all determined to be evidence-based because outcomes were measured and research was done thoroughly. Oh, there was one more, to provide informed consent. Informed consent, a way to think about this is if a client comes to your facility, you have an obligation to inform them about all treatment options that are available to them. And to qualify that, then to explain to the client what treatment options you're able to provide in your program. In other words, you may not be able to provide every option that's available to the client in your program, but you have to inform the client that other options may be available to them. An example of that would be medication-assisted treatment, like methadone maintenance. If your program doesn't provide methadone maintenance for opioid addiction, you have to at least inform the client that methadone maintenance is an option, just not at your facility. I hope that makes sense. So what does this all mean? We have a responsibility to improve service delivery and monitor client outcomes. We emphasize responsibility. These are things we have to do as professionals. The field of addictions treatment is evolving, like I've said, and will require a broader understanding of the term treatment. When I referred to whole person care, if you think of it, treating various areas of a person's life is still treatment, but it's not the traditional definition of treatment as we have understood it in this field. I think most people, when they think of treatment and substance use disorders, they think of the residential kinds of environments. Treatment is really anything that helps a person to improve their health, their situation, and their wellness. Again, we have a responsibility to stay informed about evidence-based practices, best practices, and promising practices. As professionals, we should always be challenging ourselves, questioning ourselves, and looking for the best approach and the most scientifically supported approach that would appear to work best with any given population. Especially those in leadership positions have a responsibility to prepare the next generation of leaders to be on the cutting edge of addictions treatment and co-occurring disorder treatment. As leaders, you have an additional layer, I think, of responsibility to not only improve your program, but to look at your staff, see who you can mentor to one day replace you. Therapeutic relationship refers to the therapeutic alliance that was mentioned earlier. And the therapeutic alliance involves a relationship between the clinician or the helping professional and the client. The relationship's really defined by the rapport that you can establish with the client, common or shared goals that you and the client both agree to, providing a sense of safety and trust where the client can change or feels safe enough to risk certain attempts at change. You have an ethical responsibility in this relationship as the helping professional to make sure that your intentions are always in the best interest of the client, and that you're not steering them in some particular direction where maybe they don't want to go. The power distribution has to do with that a little bit as well. There will always be this power difference between you and the client, what you say, how you behave, and the kinds of things you suggest are going to have oftentimes a tremendous impact on the client. So just being aware of yourself and of what you're doing and saying in a way that ensures that that power distribution is not misused intentionally or unintentionally. The function of the therapeutic relationship then is to provide positive reinforcement to the client. Always instill hope, encouragement, assist the client with self-efficacy, having the belief that they can do a thing. Provide the client with accurate, genuine empathy, using usually reflection skills, reflecting back to the client what they've told you in a way that captures their emotional or cognitive thought processes, lets them know they've been heard. And in partnership with the client, develop goals that are realistic, attainable, and adaptable. So we don't want to create, obviously, goals that the client realistically would not achieve. You have to, of course, base it on your client and their individual situation. Base the goals, I mean. And then model adaptive interpersonal functioning, just as the professional. Really, I think this gets overlooked a lot, but as the professional, model behavior for the client. They will likely pay attention to just about everything that you do, how you say it, etc. The benefit to the client in this sort of relationship is that they feel heard, understood, accepted, respected, and empowered. They feel the therapist is concerned through the therapist showing empathy, and the therapist is working with him or her, not just telling the client what to do. I know when I started in this profession, the general rule was to create a treatment plan with a list of goals and then present it to the client, which obviously doesn't, they might not have any buy-in to any of the goals that you've created as a therapist. So it's important to work with the client. What are they willing to do? What are they motivated to do? And what are they able to do? So you have to be realistically optimistic. And then the client will generally recognize that a positive change is possible or occurring. Again, building self-efficacy, being hopeful, and just encouraging the client can oftentimes over a period of time as you build this relationship, be very effective. Referring back to ASAM once again here. ASAM, I think this slide might be just 1 second here. All right. As a part of the assessment process, as I mentioned earlier, it's important to look at all aspects of a client's life. And it's a difficult thing. People come to us with complicated histories, biological problems, psychological problems, environmental problems. So it's important to look at areas of a person's life and using established and hopefully objective criteria, try and determine where the severity lies within each of those dimensions of their life. ASAM is clinically driven. It's not program driven, meaning the assessment does not depend on your program's philosophy or your personal philosophy, but is, again, stated in objective terms, the criteria for does this person appear to need this level of care, for instance. They're not prescribed. There's no prescribed length of stay. Again, this is a longitudinal approach and it promotes entry into a flexible continuum of care, meaning that a person can really enter the continuum of care at almost any point, really, and move around within that continuum of care based on ongoing assessment. That might not be clear. What I was trying to emphasize here was a person could enter, say, a treatment program at an outpatient level of care, show that they're not progressing based on a set of criteria, and then are recommended for a higher level of care based on lack of progress, and then do much better and again move down to a lower level of care. So it's meant to be a flexible approach, a sort of a fluid approach to recommending the appropriate service for the appropriate client need. Again, ASAM or an assessment requires informed consent, outcomes driven, and clarify medical necessity. The dimensions of ASAM, these are the areas of a person's life that a clinician would rate or assess. Usually this is described as minimal, moderate, or severe. There could be different words used there, but the idea is that in each of these areas, you're measuring what impact the person's substance use has had on this area of their life. So where I work here in this detoxification center, acute intoxication and withdrawal potential are usually rated very high as severe potential for risk. So are biomedical conditions and complications. The third dimension of ASAM is emotional, behavioral, or cognitive conditions and complications. These could be things along the lines of cognitive disorders, personality disorders, other kinds of mental health issues that would complicate treatment. 4 is readiness to change, and it has to do with the client's motivation to change. And 5 is relapse, continued use, or continued problem potential. Again, these dimensions interact and influence one another. So someone with a high continued use or continued problem potential may also have emotional, behavioral, or cognitive conditions. And those two, as an example, those two dimensions can influence one another in terms of the overall progress, that the client makes. The recovery and living environment is the last dimension and encompasses pretty much all of those influences in the client's environment that would impact their likelihood of remaining sober or would impact their addiction in some way. Sorry, at the bottom there, it's mild, moderate, or severe is typically how these dimensions are rated. This can change over time as the client progresses through treatment, so the severity ratings can change. Whole person and client-centered care is the direction the whole field is moving. Integration with mental health, primary care, such as physicians, nurse practitioners, or physician's assistants, including multiple professionals in the client's treatment process, is really the direction that we need to head. Client-centered care begins at the moment of contact with the client. So whether that's whoever that is in your organization who receives a phone call from a client, it's that initial point of contact, as well as ongoing relationships that determine oftentimes whether or not someone will be successful in treatment. The relationship here between either the program personnel and the client or the clinician and the client is essential to positive outcomes. It's essential. More so than what theory you select, more so than almost any other factor. It's the relationship that oftentimes means whether or not someone will improve or not improve. Again, multidisciplinary team approach using community support systems. ROSC is mentioned here. ROSC stands for Recovery-Oriented Systems of Care. It's a community support system that incorporates all of those influences in a person's environment that could positively impact their recovery and their health. Coordinating all of those services is a challenge, and historically, funding streams have not supported this kind of collaborative effort. Funding primarily has driven how we do treatment, and hopefully that's changing under the Affordable Care Act. Selecting a particular theoretical approach is most likely to result in the client's improved health. So as we get into some of these best practice approaches or evidence-based approaches, selecting the proper one or finding a combination of theories that appear to work best with the client is going to be your task as a clinician. And before we get into theory, I just want to see if there are any questions or if I'm not being clear about something. If not, we'll just move into theory.
It looks like there aren't any questions right now, but if you have any questions at this point, please feel free to submit them using the Q&A pod. We'd love to take questions at any time, so feel free to submit them whenever they might come up throughout the presentation.
Thanks, Kate. We're not going to cover every theory as we go through this next few slides, but if you're studying for the licensing exam, you're going to need to know a few of these theories. I've tried to select ones that would likely come up on the exam so that you at least have a very, very basic understanding of what those theories constructs are and what kinds of things separate one particular theory from another. If you're studying for the exam and you're studying multiple theories, it's best if you study one at a time and study one for a couple of days, move to another theory. It's also better if you're studying theory to select those constructs, those key elements of that particular theory that set it apart from the others. Otherwise, theories can blend together. They can become sort of difficult to distinguish unless you clarify for yourself what things about this particular theory make it different than the other ones. So I'm going to mention a few in these slides, but I'll also mention a few that aren't in the slides, just so you have an idea of what to look for on the test.
We did, Bob, if I can interrupt for 1 minute, we did have a question going back to ASAM. We have a question, what are changes for the new ASAM?
The new ASAM, I just received it, so I'm looking it over, but primarily what they've changed in this new edition, the third edition, is they've de-emphasized the placement part of the criteria. In the second edition, the name of the manual was ASAM PPC2, which meant Patient Placement Criteria, second revision. They've de-emphasized the importance of placement in this particular version. That's not to say it's not important, but what they're trying to focus on more is the criteria that distinguish what levels of care may be needed for this particular client based on the symptoms. It's also designed more to be in line with the DSM-5. So much of the language and philosophy is very similar to the DSM-5 language. Again, ASAM and the DSM-5 both look at addiction as a chronic disease, a brain disorder, primarily of the reward system of the brain. And both look at addiction as longitudinal, not time limited, and involving multiple influences on health. So I haven't looked it over well enough to give you a really, really good idea of what's in it, but it is available now. I think the copy I got was $95. But if your organization can buy you one, that would be probably beneficial. And just quickly, I think ASAM, as you move along in your careers, if you haven't already come across it, it's going to be an integral part of treatment decision making. And most states, most health plans already use it as a way to determine whether or not somebody might be appropriate for a particular level of care. So I'm sorry I can't give you a better summary of ASAM, the new edition, but it's about all I know of it at this point.
That's great. And then we had another question actually on that same topic. How can spirituality be integrated into ASAM, such as native traditional healing and faith-based services?
That's a good question. That's a good question. I think that plays into a couple of different areas. Motivation to change certainly can be influenced by spiritual beliefs, as well as cognitive and behavioral. Complications could be reduced by having a stronger spiritual foundation. There are many areas actually of those dimensions where I think spirituality can fit in more as a positive aspect to reducing the severity level for some of those dimensions like relapse potential and that sort of thing. Whenever I assess a client using the ASAM dimensions, although it's not explicitly stated in the dimensions, spirituality is certainly a factor that needs to be considered, because generally speaking, those with some form of spiritual belief or some belief in something that grounds them to a particular belief system, those folks tend to do better in treatment overall. It's a good question, and it's mentioned, I believe, in the DSM-5 as an important aspect of treating addiction. I could be wrong about that, but
great. I did want to say I noticed a couple of people have used the hand raising feature, and unfortunately we don't have the options for letting everyone ask their questions through your microphone and connecting that. So if you could submit all questions by typing them into the chat pod, that would be greatly appreciated. And I think that's all the questions we have at the moment.
All right. All right. Just a slide I think I threw in here because it had pictures. All right. So the first theory I want to focus on, and again, this is a very broad overview, but it will likely be on the exam if you're studying for it. Behavioral theory. Behavioral theory, if you think people like Skinner, Pavlov, has to do with believing that behaviors are learned and therefore can be unlearned. And then that new behaviors, new, more healthy behaviors can replace the old ones. So behaviorists focus on the observable, how people act and react and behave. They focus less on cognitive and emotional states and believe that behavior represents learned habits. Behaviorists tend to believe that the important thing to focus on is the observable behavior and learned habits of the client, and that those things can best be addressed without special attention to whatever's going on internally with the client. Conditioning is an aspect of behavioral theory. Here's where Pavlov's name might show up. But classical conditioning would be something like the Pavlov experiment where he rang a bell and gave a dog some food, and every time he did that, reinforced the dog's response, to where at the end he rang the bell and did not give the dog food, and the dog salivated, anticipating the reward. That would be an example of classical conditioning. Operant conditioning is that the nature of the consequence will impact whether the behavior occurs again. That could be, say, getting arrested for a drug charge. It could be a health-related consequence, I don't know, high blood pressure or something of that nature related to their behavior, that they then change their behavior to improve the health condition. And another example might be an abuse. If an abuse were used to discourage people from drinking, if they did drink on an abuse, they might get very sick, and the consequence of that behavior might weaken that connection between their expectation and what their result is. So under behavioral theory, classical conditioning and operant conditioning are probably the two things that would set it apart, or at least in your mind, help you to set it apart from other theories. And think of the names of Skinner primarily, B.F. Skinner. Motivational incentives or incentivizing. It's also been called contingency management. This is providing a reward for good behavior. In a treatment setting, an example of this might be if a client was able to provide, say, 3 or 4 clean UAs in the course of their treatment, that there might be some sort of reward for that, whether it's financial or some other token kind of reward. But the idea here is to incentivize clients to change behavior through providing a reward. It's been fairly well researched and shown to be effective. Of course, the problem is that most programs don't have the money to financially incentivize clients. So it challenges us to be creative with what kinds of incentives we can offer clients. But the outcomes seem to be positive for this approach. And I think the current term is incentivizing. Contingency management might be an outdated term. It may show up on an exam. Probably the most common approach used in the field, both the mental health field and the substance use disorder field, is cognitive behavioral therapy. This really developed out of behavioral theory, but added, instead of just looking at the client's behavior, added emotional and cognitive processes as an important element to treating the client. So cognitive behavioral therapy is really a combination of behavior therapy and cognitive therapy, which looks more closely, cognitive therapy looks more closely at emotion and thought processes. So this has been a very well-researched theory. It's been shown to be very effective, at least within the context of other theories. And it's most often, like I say, most often used in our profession. Cognitive behavioral therapy is often used in relapse prevention. If you've done relapse prevention groups, or even in the course of residential treatment or outpatient treatment, usually relapse prevention is a topic of choice. So identifying high-risk situations and finding skills to cope with those situations in a more healthy way. Again, to enhance self-efficacy through really paying attention to a person's emotions and the way they think about themselves and their interaction with the environment or the people around them. So helping a person to recognize not just their behavior, but how they feel about their behavior, how they think about their behavior. And challenging positive alcohol expectations is a part of that. Lifestyle balance. I think probably most of you are somewhat familiar with cognitive behavioral therapy. Again, the thing I would remember about it and the name I would probably attach to it would be Aaron Beck. And Aaron Beck has been responsible for developing the Beck inventory for depression screening using a cognitive behavioral approach. So connect the name Aaron Beck with CBT and think in terms of behavior combined with cognitive and emotional responses of the client as a way to work towards the treatment goals. Another common therapy used both in the mental health field and substance use disorder field is rational emotive theory or rational emotive behavioral theory. This is a theory that focuses primarily on errors in thinking or irrational beliefs about a particular thing. So as you think about REBT, think about treating a client by having them recognize an irrational belief about an event or a situation that occurred, and then exploring their emotional reaction to that. There's an example at the bottom. This is an obvious one that probably you've come across, but a person says, I was only arrested for drunk driving because that cop has it out for me. Someone who was using REBT would say, well, that's an irrational belief that the cop probably wasn't looking for that person. The problem was not that, it was the fact that the person was driving drunk. But that's the way that the REBT counselor would approach it. They would say, here's the irrational belief based on the situation. Here's the client's emotional response to it. They're very angry, helping the client to recognize that the situation or their beliefs about the situation are not necessarily rational and that their emotions follow that irrational belief. Therefore, by helping the person to recognize that, the theory goes, you'll be able to help them come to a different conclusion about the same event. I hope that's clear. It's sort of hard to describe these theories in the course of 1 or 2 slides, but the things to connect with REBT are irrational thoughts, errors in thinking, and the client's emotional response to irrational thoughts and errors in thinking. The therapist then tries to replace those with more rational kinds of beliefs and thoughts. Another commonly used model is the stages of change or trans-theoretical model. This was developed by DiClemente and Prochaska. Originally, I believe it was to look at smoking cessation, and then I believe DiClemente took that model and applied it to alcoholism. The stages of change are a way of looking at the change process for a person. So if you were to go through it in order, it would be, in terms of the change process, it would be someone who was pre-contemplative, didn't recognize that they had a problem of any kind, who would then, if they evolved through this through these stages, would then move to a contemplation stage at some point where they began to think, okay, maybe there is a problem of some kind, which might lead then to the preparation stage where they start to take or have some thought about what they might do about that. They're not really taking any action in the preparation stage. They're just starting to think about where might I go if I needed help for my drinking, or where might I go if I needed help for my cocaine use. But they're also preparing themselves for the likelihood that something needs to be done. In the action stage, the person actually takes some action to get help or to effectively address the problem that they're concerned about. So in the action stage, an example would be of somebody actually going to treatment or making some effort to connect with a treatment program in the case of addictions treatment. The maintenance stage is when somebody's taken action, they've made certain changes in their life, and then at the maintenance stage, maintain those changes and hopefully continue to exhibit the positive behavior. In this case, it would be, say, abstinence or at least reduced use, something of that nature. Relapse and recycle refers to the fact that sometimes people have a recurrence of use and might re-enter the stage, an earlier stage of change, say at the contemplation or even pre-contemplation levels. So a person can go through this whole change process from pre-contemplation to maintenance, have a recurrence of use, and then revert back to maybe an earlier stage of change. But that's how it's designed. It's designed to be that way, where no matter where the person enters the readiness to change, they can progress or maintain those changes, hopefully, at the end of the cycle. All people go through this process, whether it's addiction, whether it's buying a house, or buying a car, but everyone goes through this process to some degree. This is a nice way of looking at it and helping to clarify where a person might be at in terms of their motivation. This is a long, wordy slide about motivational interviewing. I'd like to mention here, you can read this while I talk, but motivational interviewing developed out of Carl Rogers' theory of a client-centered approach. Carl Rogers believed that clients should be regarded with unconditional, or should be approached with unconditional regard. They should be accepted. Whatever they say, whatever they think, should just be accepted. There's no confrontation. The client is really the person that drives the treatment process. Miller and Rolnick took that idea, that theory that Rogers developed, and further developed it to include some additional aspects that make it more directional. That is, motivational interviewing, while not confrontational, does provide direction to the client. You do that through developing discrepancies with what the client is telling you versus what reality might be. You do it by raising awareness about a particular issue with the client. And you do it by using Socratic questioning or very targeted questioning that allows you to examine or help the client recognize certain aspects of their life where they might be willing to make some changes and might see some motivation to do something differently. It's much more complicated than that. I think the primary thing to remember here is that there's motivational interviewing developed out of Carl Rogers' client-centered approach, and that motivational interviewing is not just a copy of that approach, but that it incorporates additional constructs that involve directional focus. There needs to be extensive training to properly do motivational interviewing. I think a lot of people, a lot of clinicians believe that they use this approach because they're client-centered, but that's not necessarily true. There are very specific techniques that one must adhere to when using this approach in order for it to be used as intended. And I think one of the most important things to remember about this approach is that the counselor needs to roll with resistance. In other words, if the client shows resistance during the counseling session, it's an indication that the counselor is doing or saying something that maybe is causing that resistance. So it creates a situation where the counselor would back up, look at what they're doing and how they're doing it, and try a different approach to get the same, hopefully the same outcome. But resistance is viewed as not a client issue, but it's a therapist issue. The therapist is doing something that's creating the resistance on the part of the client. Rolling with resistance. And it's a tricky thing to actually do in practice. Those of you who have had motivational interviewing know that it's a fairly complicated theory or approach, and it requires a lot of training. So collaboration, evocation, autonomous self-rule, empathy, not sympathy. We all probably know that. Develop discrepancy, roll with resistance, and support self-efficacy. I think these kinds of things is what I would focus on for the exam if you're taking the exam. And this I already spoke about this, so I won't dwell on it. SBIRT. Brief interventions are a more commonly used tool and a very effective tool if used properly to provide early intervention for people that maybe have screened positive for substance use disorder or mental health disorder. Screening, brief intervention, and referral to treatment is what SBIRT stands for. It's usually a 3 to 5 minute process where a screening tool is used to assess a client's risk of having say a substance use disorder. So it could be something like the CAGE, the MAST, or one of those screening tools, one of those brief screening tools where 4 or 5, 6 questions are asked of the client. And if they meet whatever the criteria is for the screening tool, but if they meet 2 or 3 of those criteria, then they might, according to the tool, have a substance use disorder. If they screen positive, that is, if they screened as having a high risk for substance use disorder, then a brief intervention would follow. Again, about a 3 to 5 minute discussion with the person, the patient or the client, that says, you know, you screened positive based on these questions, and I'm just wondering if there's, you know, any concern on your part about this issue of substance use or whatever the concern might be. And just having a brief sort of non-confrontational, comfortable discussion with the client about your concern, but also exploring whether or not they have any concerns. If there is consensus, that is, if the client and you feel there is a need for further assessment, the client's willing to do it, then a referral would be made to probably a treatment program or some longer-term care facility that could better assess the client. It's a process that takes a lot of skill. It's hard to establish a quick rapport with the client and build and have their trust in the matter of a few minutes. But I think by virtue of not being confrontational, by being sensitive to the nature of what you're asking the client about, and again, just asking for their input as to whether or not they're concerned, those kinds of things can go a long way into developing a longer discussion with them about what maybe they could do if they are concerned. Treatment would be the end result if somebody actually followed through with the further assessment process and entered treatment. Again, it's been shown to be very effective. Oftentimes this is an approach used in clinics, doctors' offices, non-substance abuse treatment facilities. It can be used really anywhere by a professional, and you know, if this is done by a physician, clients tend to put more stock in what a physician has to say versus maybe a case manager. So there's some status there that has an influence also on whether or not the client really wants to discuss the problem. I'm not saying that's right or wrong. I'm just saying that tends to be what the case is. So SBIRT would be something to think about in terms of best practices or current best practices. It's also reimbursable now through the ACA. These are other theories that are worth mentioning, but probably wouldn't be on an exam. These are public health models for behavior change theory. One is the social cognitive theory. The other two are health belief model and social ecological model. I like these theories in particular because they look more broadly at environmental influence on behavior. They look more broadly at all of those things that can influence whether or not somebody wants to change a behavior, including their perception of the reward and the perception of the risk, as in the health health belief model. The social ecological model is really what ROSC is based on. ROSC, again, is the recovery-oriented systems of care. Social ecological models take into account, as I've talked about, multiple influences on behavior, and states that behavior both shape and are shaped by the social environment. These kinds of approaches make a lot of sense to me. I think the longer I've been in the field, the more I've recognized how health is influenced, including addiction, is influenced by a whole variety of factors. And the more broadly we can look at those factors, the more we can sort of determine which factors have the most influence on the client, I think helps to improve the efficacy of our treatment approach. So I mention these only because I think they're worth reading about and learning more about if you haven't heard of them already. I'm going to talk quickly about integrated care and co-occurring disorders. The last few slides have to do with buprenorphine, and I'm going to probably go over this fairly quickly. I don't know that that's going to be especially important for you to know about, but if you do have questions about that, I don't want to totally ignore the impact of buprenorphine on medication-assisted treatment. But right now, behavioral health and integrated care. Finally, the addictions field is recognized, and the mental health field is recognized, that the clients that we serve are generally people that have both conditions. Not always, but most often, the clients we serve have both mental health issues and substance use issues. Now, some of the mental health issues might be substance-induced, that is, they're related to the drug use or the alcohol use specifically. Other mental health conditions might be independent of the substance use. But in either case, both fields have to really combine their efforts here and look at, again, the whole person and treat the whole person. Historically, what we've done is we've treated someone for one of these things, substance use or mental health, and then we've sent them to the other place for treatment. There's been no real integration until recently, I would say, of co-occurring care. The other thing to consider here is primary care, which is equally as important. Because addiction has a biological cause oftentimes, or the effects of addiction are biological in terms of the brain disorders that can come from it, primary care needs to be in the discussion along with mental health and substance abuse professionals. It cannot be excluded. Primary care cannot be a separate thing and shouldn't be. Substance use and mental health disorders should be brought into the realm of general healthcare. It should just be a part of healthcare. And primary care obviously is already standard for most healthcare. Problem gambling, also in the DSM-5, is listed as an addiction disorder. Many of the processes that take place in the brain and the reward system of the brain are identical or very similar to substance use disorders. So the two, in the DSM-5, the two were seen as similar enough that they could be categorized in the area of addictions. So co-occurring disorders are generally described as the presence of at least two disorders, one being substance use, and the other being mental health disorders such as listed here, major depression, bipolar disorder, schizophrenia, or PTSD. In the DSM-5, PTSD is its own disorder. The DSM-4, it was listed as an anxiety disorder. Things to remember if you're taking the exam would be to study for some of these co-occurring disorders that most often present, like major depression, bipolar disorder, schizophrenia, and PTSD, and anxiety, actually. If you're studying for the exam, look at those major, those 5 or 6 most prevalent mental health disorders that present when somebody comes to substance abuse treatment. The other thing to look at would be personality disorders like borderline personality, antisocial personality, and possibly, geez, I can't think of it. I'll think of it later. But look at personality disorders also if you're studying for the exam.
Bob, if I could interrupt for a minute, we do have a question. I'd like to take a question at this time. The question is, mindfulness training has been shown to be beneficial in treatment. Are there any evidence-based practices?
For mindfulness treating? I know what you're referring to, but I don't know enough about it to comment on that. I can find out, though. If I can find an answer to that, I'll send an email to Kate.
Yeah, and I'll be happy to pass that on to all those who attended today. So
okay.
That's all we have for the moment.
All right. Right now, there's an emphasis in the treatment field to look at this group of folks, this group of people with co-occurring disorders, and find a better way to approach their care. I'd like to say that's because we're all of us in the field are empathetic and sympathetic to this population. That's part of it. Part of it's also financially driven. This population they actually use the most expensive forms of healthcare most often. So this population with co-occurring disorders is more likely to use an emergency room for their healthcare, or use a detox center, or be arrested and go to jail. In any of those cases, they end up costing society a lot of money. And that's okay in a sense, because that is a tool we can use to advocate for better treatment approaches for this population. So by making that sort of the focal point of why we need to treat this population in a different way, possibly that would be more effective, is just fine by me. It would save money, and it would improve the quality of care for these folks. Again, the kinds of things that we're looking at in terms of what approaches to use are primarily integrated and coordinated systems of care. So we're looking at ways in which we as treatment providers can communicate more openly with other kinds of social services and primary health care, so that we can coordinate the way we do business, the way we develop the client's care plan, and together work with the client in a coordinated fashion. So there is a thing, I don't know if you're familiar, any of you are familiar with it, but there is a tool that substance abuse treatment programs can use to provide information to other facilities without client consent. There's some restrictions to it, but it's called a Qualified Service Organization Agreement, or a QSOA. This is a formal agreement between the substance use provider, treatment provider, and another program. Now, the other program has to provide some similar service or some beneficial service in order to qualify. There's some other things to look at. But it does allow for two organizations to speak openly about specific clients without individual client consent. I just ask, if you're interested in looking into that, you can Google QSOA, or Qualified Service Organization Agreement, and read more about that. But we've implemented some of those agreements here in St. Paul, and it has allowed for some collaboration that otherwise wouldn't exist. The axes no longer exist in the DSM-5, but if you're taking the exam for certification, it's still, I believe it still focuses on DSM-4 criteria. So if you're studying for that exam, you'll need to know the axes based on the DSM-4 TR. Axis 1 is listed here as reporting all the various disorders or conditions in the classification, such as substance use or mental health disorders, except for personality disorders and mental retardation. Axis 2 is for personality disorders and mental retardation, and may also be used for noting prominent maladaptive personality features and defense mechanisms. One of the personality disorders that I couldn't remember a little bit ago is narcissism. Studying narcissism, antisocial personality disorder, and borderline personality disorder can also get very confusing. So again, if you're studying those, be very careful about deciding which elements of each of those disorders would help you remember to distinguish them. I'm not going to go into axes too much here, but if you are taking the test again, you'll want to study the axes and know what they are for. Co-occurring disorders can also be assessed using the ASAM criteria. The new version does place emphasis on co-occurring disorders and helps, as a clinician, it helps to describe how to assess somebody in those situations using those same dimensions of health that were mentioned earlier. Also, in assessing a co-occurring disorder, you want to, under these bullet points, obtain longitudinal history of mental health and substance use symptom onset, and determine whether sustained abstinence leads to rapid and full remission of the mental health symptoms, which helps to tell you if it's substance induced or not. Again, I personally don't think it's that important at the moment to know whether it's substance induced or not. The important thing is to treat both symptoms or both conditions concurrently. Here's some characteristics. Yes.
Oh, I was just going to say, we have a question about integrated care. What models or tools are there for integrated care?
There's several. One is the ROSC model, Recovery-Oriented Systems of Care. You can go to SAMHSA. SAMHSA is the Substance Abuse and Mental Health Services Administration website, and find a lot of information about ROSC. Another way to look at integrated care is through the movement that's becoming popular now called behavioral health homes or health homes. For quite a while, there's been patient-centered medical homes, which are primary care systems that look at how to coordinate care within the primary care system. Now, we're looking at ways in which to do that in the behavioral healthcare system. It involves some of the things I've talked about, but behavioral health homes are sort of the mechanism by which you can offer integrated care. And I'll try and explain that. Behavioral health homes serve a function of providing either in a physical location or virtually, or both, a list or a menu of services that a person can take part in. So if a person needed, say, housing assistance, employment assistance, substance abuse treatment, mental health treatment, and possibly some physical health treatment, that all of those things would be available and coordinated by a case manager or care coordinator. So the health home would offer this variety of services, a menu of services, and the care coordinator would be the person or the persons that assist that client in making the connections to the various services and coordinating the care for the client between those services. So someone is always following the client and making sure that they're not receiving care independently, from different places that aren't talking to each other. I hope that makes sense, but look for behavioral health homes or health homes and read about them, because they're probably going to be very common in the near future, and they're already fairly common. I think Missouri, the whole state of Missouri, has based their Medicaid system on a behavioral health home model. I know here in Ramsey County, we're spearheading a lot of efforts to develop health homes that are more integrated and coordinated. Just more characteristics of co-occurring disorders. I don't need to read them to you. There's some difference in assessing co-occurring conditions in adolescents. are some things to consider that are different with adolescents. The new version of ASAM does have a set of criteria specific to adolescents. So there is a developmental consideration made when looking at criteria that might determine which level of care to refer an adolescent to. That's in the new version of ASAM. Just a couple of characteristics that are mentioned here is that 90% of adolescents with a lifetime co-occurring disorder had one mental health disorder prior to onset of substance use, and that the median onset of mental health disorder was about age 11, and the onset of substance use was between 16 and 21. These are just general characteristics of what we see with adolescents with co-occurring disorders. Usually schizophrenia, and I would say personality disorders tend to manifest in late adolescence and early adulthood. Not always, but usually. This is sort of a dated model. I think you're going to see this change a little bit. But the locus of care, or the quadrants of care where people have typically been referred to, was based on this. If you look at the severity ratings on the X and Y axes there, people with high severity of substance use and low severity of mental illness typically went to substance use treatment programs. And just, the opposite, people with high mental health risk factors and low substance use went to primarily mental health systems for care. What I think you're going to see moving forward is a real blending of all of these things. It's going to be harder to distinguish really where that person is receiving care, because they're going to be receiving it from all of these areas. I don't know about jails and prisons, but even hospitals and primary care settings will have a behavioral health component to them, and addiction treatment will have a primary health component to them and a mental health component. So this is all going to kind of blend together, I think, moving forward, and these quadrants will become, if anything, just a way for us to sort of gauge severity in a particular area. But as far as care goes, it'll be a shared responsibility amongst all of these things, all of these places. I'm not going to talk too much, as I said, about buprenorphine. Let me just talk quickly, and then I'll see if there's some questions before we run out of time. Pharmacotherapy, or medication-assisted treatment, is gaining some attention, not just for methadone maintenance or buprenorphine or Suboxone, but also for medications that seem to assist with helping with cravings for alcohol, cocaine sometimes, and nicotine primarily. But there are some drugs available now for alcohol that do assist with craving, at least in a percentage of folks. I think, and I could be wrong, but I think it's about 70% of those that take, say, naltrexone to help them with their alcohol craving find some benefit in doing that. Problem with it is it tends to be expensive, and most health plans, at least that I'm aware of, don't pay for it. So people are excluded just by virtue of not being able to afford it. Detoxification medication is used not just in methadone, but oftentimes benzodiazepines are used to help treat withdrawal symptoms for alcohol withdrawal. Alcohol withdrawal can be life-threatening, and the risk for seizure, the risk for delirium tremens is there, and depending on the person's history, they might be treated with a benzodiazepine like Valium, and then taper off the Valium just to prevent seizure and prevent hallucinations and reduce tremors and that kind of thing. Buprenorphine and methadone and Suboxone are often used for opioid maintenance, and have been shown actually in research. The relapse rates decline dramatically when someone is using something like methadone or buprenorphine in a long-term maintenance regimen. And whether you agree with that or not, I'm not trying to advocate one way or the other, but just being objective and looking at the research, maintenance programs with opioid addiction especially tend to have much better outcomes than for people that don't take maintenance medication-assisted treatment. I think the relapse rate drops off by about 70% after 6 months. I could be a little wrong about that, but it's a dramatic change. These are just some of the drugs used for alcohol disorders. Naltrexone, as I mentioned. Vivitrol is the injectable form of naltrexone. Disulfiram is antabuse. Compressate and serotonin reuptake inhibitors. Serotonin reuptake inhibitors, I think, would include some antidepressants like Wellbutrin. Don't quote me on that. I believe so. And just quickly, there's a difference in terminology here between opiate and opioid. Opiate is a more specific term that refers to drugs or medications derived from the opium poppy. They include drugs like heroin and morphine, codeine. Opioid is the larger group of drugs that include synthetic drugs, say oxycodone, and drugs like pain medications like that. So opioid is the general larger category or umbrella of opiate-like drugs. And oftentimes opiates or opioids are used primarily for pain management. Methadone is also used for pain management. The withdrawal, if you're, again, just a tip if you're studying for the exam, you'll want to focus on drugs of abuse, obviously, and all of these things that are listed on this slide. But withdrawal would be something also to focus on for the exam. You don't die from opioid withdrawal. You might wish you were going to die, but you won't. Alcohol withdrawal, on the other hand, is could be very life-threatening. And benzodiazepine withdrawal as well can be life-threatening. There's just a quick fact. There's a real, it's very difficult when somebody comes into a detox program who is alcohol dependent, but also takes benzodiazepines, maybe for anxiety disorders, because you have to be very careful about administering a benzodiazepine to a client who's intoxicated, but who also may already be on a benzodiazepine. The obvious reaction could be that you inadvertently lower their respiration and autonomic, or their respiration and their primarily that can lead to respiratory failure just by sedation of the bodily functions. And I'm not thinking of the words I need to use, but you know what I mean. Just some history about opioid addiction, or treatment, I should say. And I won't focus on this too much. In fact, we're getting close to the end, so I just want to see if there's anything that I might want to mention here before I close. Myths and facts. This is something as clinicians we need to sort of be aware of. Addiction is a pathologic use of a substance and may or may not include physical dependence. Physical dependence on a medication for treatment of a medical problem does not mean the person is engaging in pathologic use. So if a person is dependent on pain medicine for a chronic pain condition but takes it as prescribed, then we wouldn't consider that pathologic use. It would be using the medication as intended, even if they were dependent on it. Just some facts about buprenorphine. It's taken under the tongue. It's very safe route of administration. And generally speaking, people function quite normally when they take it. You know, it's been long-standing wisdom that medication-assisted treatment in combination with therapy is more effective. I tend to believe that, but there is some research out there that indicates that medication-assisted treatment alone has the same outcomes as when it's paired with talk therapy. I'd have to look at those studies more closely, but there's some indication that the outcomes are the same, whether the person has therapy or just uses the medication for management of their symptoms. Patients don't get high when they take buprenorphine or methadone. At least if they take it as prescribed, they won't. I'm just going to skip along here. Nicotine replacement is probably pretty commonly known. Let me just ask if there are any questions before I run out of time here.
Yeah, we do have a couple of questions, but yeah, I just want to encourage everyone now, as we have a few minutes left, to submit those so we can get through as many as we can. A first question is a follow-up, RE, the mindfulness question earlier. She says this refers to meditation, and there's quite a bit of research that shows it can be effective with substance treatment. So did you want to respond to that at all, Bob? Or?
Yeah, actually, that helps me understand what you're talking about. We've done some trials here in the detox center using meditation as a method of helping reduce symptoms of withdrawal and seeing how effective it was in this kind of environment. There hasn't been a lot of research done in a detoxification center environment to see what kinds of interventions are effective. So we had a doctorate levels nursing student here as a practicum student, and she was more familiar with what you're talking about and more familiar with ways to use that sort of approach in these kinds of settings. So we let her do that. We let her do meditation groups with detox clients, and then we evaluated both the clients' response to that, how effective they found it, was it helpful, and that sort of thing. My initial findings from that, we probably received, I don't know, around 100 surveys just from that particular intervention. Almost all of those responses from the clients were positive. So it tells me that that sort of thing, providing, if nothing else, an opportunity for people in treatment or in withdrawal, providing them with the opportunity to meditate, to have a guided meditation or just a quiet place where they could self-meditate, is an effective way to address this. And it makes sense to me. I just hadn't measured it before, but I would agree that that's a promising practice, if not a best practice. I'd have to look at the research around it.
Great. And hopefully everyone will see, we had one of the participants sent me a list of resources, websites. So please take a look at that, and I'm sure there's a lot of helpful information there. And then another question that we have is, are there any SAMHSA resources for the new ASAM guidelines, since the book is quite costly?
Well, I suspect they will give a brief overview of what's in the ASAM, but they probably won't give away much of the content because the ASAM is, they want you to buy the ASAM, right? So I think it would be a copyright probably violation to go into too much depth. The ATTC did send out, the Home Office did send out a summary in one of their newsletters that did describe some of the characteristics of the new version of ASAM that are different, or some of the philosophy changes that are different than the old version. And that was about a 2-page summary that pointed out, specifics, but the book is very detailed and very, you really have to, in order to understand ASAM and use it well, you really have to have the information that's contained in the book itself. And I'm not promoting the book. I don't have any vested interest in that. But I'm just saying from experience that understanding the actual book is probably, you have to buy it to do that. I don't think anybody's going to publish anything that's going to take the place of that knowledge.
Okay. We just had another comment from someone that NADAC has a webinar training today in 35 minutes. So it looks like that one is happening at 2 o'clock Central Time. And it looks like that is understanding the new ASAM criteria. So that might be good for folks to check out.
Yeah, probably would be good for me to check out.
Okay, I think that's all the questions we have right now. If you want to, if anyone wants to submit any, please do so, or before we close out in the next couple of minutes. I'll just take a moment to go through my final instructions, and then if we have any other questions come in, I will check back before we close out. But let me just go through some final slides a moment. Please stay online as we close out the webinar so you can be redirected to our survey. If the survey doesn't automatically pop up, you may copy and paste the URL on the closing webinar screen to access the survey. Also, watch your email inbox for our follow-up, which will include a link to the recording of this webinar. We hope you'll be able to join us for the next webinar in this series, Clinical Evaluation Assessment with Denise Casillas on Wednesday, April 16th. And we also, as we mentioned earlier, have a webinar in our American Indian and Alaska Native Behavioral Health series on April 2nd, which will be called Cognitive Behavior Therapy for Substance Use Disorders. Again, we thank you so much for joining us today, and I want to thank Mr. Rarrett for giving us lots of helpful information, and for everyone for sharing resources and just being a part of this great discussion. Somebody just asked if I would email the list of mindfulness resources. I will absolutely do that. I will include that in my follow-up email to everyone. And then Kristen, who shared that, just shared her email, so I will let me pass that on as well. And it looks like that is all the questions we have. Let me just pass on this information for the NADAC webinar that was sent as well. And do you have any closing thoughts, Bob, before we finish up?
No, I just wanted to thank everybody for joining us today.
Great. All right. So yeah, those things that people passed on, I will be sure to include those in my follow-up email. And yeah, just thanks again for participation. And yeah, it looks like everyone wants to share their thanks with Bob for this great presentation. And at this time, we'll just close out, and you'll be redirected to our survey. Thanks again.